Often what we see with people who have endometriosis is that they get a lot of other effects that are separate to the endometriosis lesions. And frequently, we see problems associated with pelvic floor and pelvic floor function.
In terms of that area of the body where we have our reproductive tract, we have where we pass urine and where we pass a bowel motion, there are a range of structures that you will hear about: the pelvic floor, the perineum, and the perineal body.
Pelvic physiotherapists are a great resource for young people with endometriosis. If we can establish good functional control of the muscles early and good exercise habits, hopefully then we can prevent some of the downflow effects of endometriosis.
The pelvic floor is actually a really important but relatively thin muscular sling that sits across the bottom of the pelvis, and it acts as a bit of a protective mechanism. And if you think about it, if you've got endometriosis lesions and it hurts, either when you're getting a period or when you're using your bowels or bladder or when you're having your intercourse, one of the things that the pelvic floor might do is to contract to protect that area.
So when we look at the pelvis, we have the pubic bone at the front. If we turn it around, we have the sacrum at the back. So these are the big bones of the pelvis on either side. And then underneath are where all of the muscles are. Now, the pelvis or the pelvic floor actually also includes all the organs.
We've got the levator muscles, which sit deep in the pelvic floor, and we've got the superficial pelvic floor muscles, some muscles that surround the back passage and surround the vagina.
When functioning well, the job of these muscles is to help support our pelvic organs, maintain continence of the bladder and bowel, add to sexual function, and it also forms part of our core muscles.
So the pelvic floor is really the support structure for the entire pelvis.
When you hear about pelvic floor, quite often we hear about pelvic floors being weak, and this is usually after delivering a baby vaginally. But more commonly in endometriosis, in fact, the pelvic floor muscles can get short, tight, and overactive. And one of the simple reasons for this is when we're in pain, the muscles contract or spasm to guard or protect us against this sensation of pain.
The difficulty with the pelvic floor is that when we start using terms like strong or weak, we tend to associate strong as good and weak as bad. Saying that, the pelvic floor also has what we call as a baseline tone. This is the amount of support your pelvic floor provides just at rest when you are not squeezing or actively relaxing.
We do know that up to 90% of women with endometriosis or bladder pain syndrome or IBS can actually have dysfunction in their muscles, which means that they're not turning on when they need to, relaxing well, and have enough range of motion.
It's important to have your pelvic floor assessed. That way you'll know if the muscles are tight, short, or over-contracted. And the exercises that you learn to do may be exercises that are for relaxation rather than strengthening.
People with endometriosis often have pelvic pain, which makes their pelvic floor muscles pull up in response to the pain. It's almost like a coping mechanism, trying to keep the pelvis really still.
That inability to then relax down will mean that they will experience symptoms across their bladder, their bowel, or their sexual function.
This can include abdominal pain, back pain, pain that can radiate into your thighs and groin, bowel dysfunction such as pain to empty your bowels or incomplete emptying of your bowels or constipation, pain to urinate, straining to urinate or high frequency of urination. There can also be symptoms of pain or difficulty using tampons, pain or difficulty having intercourse, or pain after intercourse. When we talk about the pelvic floor, usually we're talking about that deeper set of muscles that sits 3 centimetres inside our pelvis. This is different to the perineum, which is the most superficial or outer layer of the pelvis.
Now, if you ever look underneath around the entrance to the vagina, that area, you'll notice that there is a piece of tissue, skin, that actually is from the back of the vagina to the anus. That skin that is there is what we refer to as the perineum.
The muscles around the perineum tend to have a constricting or sphincteric type actions.
Now, when the muscles are very, very tight, which we often see with endometriosis, those muscles shorten, and often that perineal distance from the vagina to the anus will then become shorter as well.
In females, the primary function of the perineum is a function of support. So it's an area where the connective tissues join together. They support the back part of the vagina, they support the front of the rectum, and having the perineum allows us to perform the functions of passing urine and opening our bowels and performing those functions correctly and well.
And it's also a really important place for the exit tubes of the urethra, the vagina, and the rectum.
Just inside of that area, from the vagina to the anus, just underneath the skin is a structure called the perineal body. And it is this fibrous muscular mass that sits in the centre there, and it's an anchor point for all the muscles to join into. And that's what helps to secure that centre part of the base of our pelvic floor. In terms of when we investigate the pelvic floor to see whether it's functioning optimally or whether improvements can be made, there are a range of tests that can be performed. One is the use of ultrasound. Ultrasound can be done via the abdomen, or it can be done underneath with an ultrasound transducer pressed against the labia and perineum. This gives an image of the pelvic floor muscles and the structures such as the bladder, vagina, and rectum, and when the muscles are contracting and relaxing, we see the movement of those organs. Ultrasound doesn't allow us to check individual components of the muscle or to see if certain aspects of the muscle are sensitive to touch.
The most common test to determine if there's pelvic floor dysfunction is a vaginal examination performed either by your gynecologist or pelvic physiotherapist. This examination will involve observation of how the muscles are working and also palpation of the muscles to determine sensitivity or dysfunction.
Now, what palpation means is as a finger examination that either is looking at the skin and how well we can see the muscles moving on and off, or we use a single finger to feel at the level of the muscles or then deeper. What we're really trying to do though is not create lots of pain, because when pain is present, everything just tenses up.
And we can use pressure sensors such as peritrons to determine how much pressure or tension is within the vaginal walls, or electromagnetic feedback devices, which gives us an idea of the electrical activity within the muscle.
So physiotherapists, particularly pelvic floor physiotherapists, can use electromyography, which picks up on the electrical activity produced by the muscle, or we can use stretchy devices that work out how passively stiff the tissue can be. Usually this is done with complete education prior to doing it, because our main aim is to be able to assess without ramping up a pain.
In terms of treatment for any pelvic floor issues, there are a range of options that we have. One of the first options is usually the simple prescription of pelvic floor muscle training exercises. This can involve teaching the woman how to contract correctly, but also how to relax correctly.
So when we're looking at treatment, I might be going, there's stretches that we start with. We start with lengthening around the pelvis, child's pose, yoga postures, or it might be relaxation to get the entire nervous system just to volume down. And that means the muscles also won't be yelling at us as much.
We can use other external full body exercises and stretches to help facilitate this awareness. And your physiotherapist may also add in gentle stretches or the use of dilators or pelvic wands.
And a vaginal dilator is a small plastic tube which is of incremental sizes. So there's some that are smaller and some that are larger, depending on how much stretch might be required. And they're used to gently and progressively lengthen and relax the muscles of the pelvic floor.
So because there can be quite a lot to cover, expect that rehab should take several months. Exercise is a really big topic, and we do know it can both help the pelvic floor pain, but it can also make it worse. And this is where the role of a pelvic floor physiotherapist is really important.
People with endometriosis often report that exercise such as walking, yoga, swimming, and Pilates are exercises that they find beneficial.
We've got to find the balance of exercise for you, one that allows the muscles to move well, but also to relax well. And that actually may change throughout the cycle.
And the exercise program, the type, duration and intensity needs to be individualised to the person.
Exercise and movement is one of the most important things we can do to stay healthy, functioning in day-to-day life. And so before we start to be worried that our exercise may react with our pelvic floor, have that assessed, because for a lot of women, it will be absolutely fine to continue all the exercise and day-to-day function that you like to do.
Other treatments for pelvic floor dysfunction can include mindfulness and the management of life stresses.
There is the use of heat or ice, generalised getting into a pool and even just walking around.
Making sure that you keep a good general healthy lifestyle, keeping good bladder function through appropriate fluid intake, good nutrition and diet, making sure you optimise your bowel function in the same way.
There are some medications which can treat pelvic floor or perineal pain, and sometimes these are medications that you can take orally. Sometimes they're a cream that you'll put onto the vaginal area.
We have learned over a number of years that injections of Botox into the pelvic floor muscles where they are in spasm and pain can be helpful. It's really important that it's done by someone who knows what they're doing and isn't done by people who might be putting Botox into the face, for example, for cosmetic reasons. There are a number of people around the country who have skill and expertise in injecting Botox, and it's not a common procedure, but it is something that can be very helpful and beneficial to people who have persistent muscular spasm and aren't responding to conservative management options.